Good afternoon, everyone. Thank you for joining us today. My name is Ashley Ring, and I'm the Associate Director of Public Education here at the American Kidney Fund. Based on feedback we received from you, we are doing this webinar on maintaining a healthy weight pre and post kidney transplant. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we're glad that you've joined us today and hope you'll recommend this webinar to the patients who you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Brent Miller. Dr. Miller is a professor of medicine and clinical chief of nephrology at the Indiana University School of Medicine. He attended medical school at the Washington University School of Medicine in St. Louis, Missouri, where he also specialized in internal medicine and completed his renal fellowship. Dr. Miller has earned several honors and awards, including the United Way of Greater St. Louis Health Professional of the Year Award in 2000. He is a member of the American Society of Nephrology and the American Society of Transplantation. Dr. Miller has contributed to numerous publications and currently serves on the editorial board for Nephrology News and Issues. Thank you, Dr. Miller, for joining us.
Thank you. Can you hear me?
Yes, we can.
All right. So thanks for inviting me. This is a very interesting topic. And it's actually, as we'll see, there are a lot of different directions we could go and talk about this, all of which we could talk about for a long period of time. And I'm sure some of you will ask questions that delve into this, but for example, just thinking about, well, if the transplant center told me I had to lose weight before my transplant, how do I best do that as a dialysis patient? And that seems like a relatively straightforward question, but it has a lot of ifs, ands, and buts, and that question itself would probably need 45 minutes to answer if we wanted to do it in detail. So there are all kinds of interesting questions and thoughts that come with this topic. So I welcome your participation, and I've interspersed a few questions in to kind of get everyone to think about this. And here's the first one. So in the United States, the average weight gain in 1 year after kidney transplant is approximately what? And actually, I'll wait for you to tell me when to continue. So interesting, and most of you got it wrong. It's the average weight gain, believe it or not, in the United States is over 20 pounds in the first year after transplant. The good news about that is that most of the weight gain does occur in the first year in most of the patients, but the average weight gain typically in the United States is greater than 20 pounds. It differs vary region. So for example, in the part of the country that I was born and grew up and went to medical school and worked at, we're on the higher side. We're closer to 30 pounds or more in the Midwest, if you take this broad belt from the south to the north in my area of the country, and the weight gain on the coast is a little bit less. But it's a significant amount of weight, and almost no one loses weight after a kidney transplant. So that's one of the reasons why we want to start our lifestyle and our diet and our activity prior to transplant, because it's going to be very, very difficult to lose weight after transplant. Next slide, please. So the question is, why does this happen? And I wish I could give you a simple answer. Obviously the simple answer would be, well, our bodies are engines, they're machines, so our caloric intake is more than our caloric output. And it's as simple as that. And to a certain degree, that's true. You can't escape biochemistry and physics and so forth. So there's a caloric imbalance after kidney transplant. The question is, why does that occur and what do we do about it? And there's no simple answer to that. But diet is a large part of it. And the reason being is, and that is complex. We think people's appetite improves because they feel better. We think there's a psychological component to where now I don't have as many restrictions as I've had the last several years, so I'm going to be more liberal. There are those sorts of things, but the diet that we choose pays attention to this. The other thing also is that the renal diet, as we'll talk about in a minute, tends to be a little bit higher in fat and carbohydrates than the recommended normal American diet. And so if those parts of that diet continue and you just liberalize the potassium and phosphorus restrictions, but you keep that amount of fat and carbohydrate that you were told to eat prior to transplant, that's a problem with the diet too. The medications can definitely impact both your appetite and your metabolism. So for example, prednisone or steroids are well known to stimulate people's appetite. Additionally, both prednisone and tacrolimus or Prograf are what are called diabetogenic. So they make you more likely to have high blood sugars. And then there's no question that there's a change in metabolism when you go from kidney failure and dialysis to kidney transplant and kidney function. And the way this isn't well described, but the way I like to tell my patients two things. One is that you have to burn calories to stay alive on dialysis. And it's not as severe as what we see in some people who have cancer. But if you think about one of the symptoms of the cancers that people have is weight loss. And there are a lot of reasons for that, including production of some compounds called cachexin and so forth. But there's an anorexia that goes along with having kidney failure that's resolved. And so you burn calories just to stay alive. And so my next analogy would be, it's a little bit like replacing the engine in a car. So prior to transplant, you have a big SUV engine that maybe gets 15 miles per gallon. Well, now all of a sudden you get a functioning kidney, which is more like those little efficient Toyota Corolla engines that maybe get 40 miles per gallon. So you don't need as much gas to run that engine that's 40 miles per gallon as you do it's 15 miles per gallon. This is not well described in science. We're still working on that as to what that change in catabolism and metabolism is after kidney transplant, but that's how I like to explain it practically to my patients. Next slide. So many of you, and I'll be interested to hear it in the question section, is maybe you've been told that by the transplant center that, well, we will not do your transplant or we won't put you on the list until you lose weight to get to X weight. And so the question is, why is that? So the obesity at the time of kidney transplant has been associated with which poor outcome after transplant. So why are the doctors telling you this? More rejection, lower kidney function, less survival of the patient, wound healing complications, or all of the above. Correct. Well, okay, we have good students on the line here. You're correct. So initially, so when I was a fellow 20 years ago or so, the initial data suggested that the major complication to obesity and kidney transplant was the last one, which was wound healing complications. But more recent data has suggested it's also associated with less overall patient survival, a lower amount of kidney function after 1 year, and then also slightly more rejection. Why those things are, we're not sure. The less survival, we think, is due to some of the comorbidities that go with being overweight, including diabetes and high blood pressure and high cholesterol. Why patients get the lower kidney function and slightly more rejection when they're obese, we still haven't quite figured out. The wound healing complications are fairly obvious, and those can be fairly dramatic. And for example, if your wound dehisces, so it opens up, then all of a sudden you have to have a wound vac and wound care and so forth. So all of those occur with the wound healing complications being the most common. But this is the reason that the transplant centers are often saying, we want you to lose weight to get to a BMI of X. And different transplant centers and different surgeons have different targets, usually somewhere between 32 and 40. But this is why they're telling you that you need to lose weight. If you're disappointed in that outcome, I would suggest you can always get a second opinion in another transplant center. The other thing too is that there are a few people who are on dialysis who are large muscular people. And as you know, the way we calculate body mass index doesn't take that into consideration particularly well. For example, if you were an offensive tackle for, name your team, the Indianapolis Colts, you maybe have a lot of muscle and a little bit of fat, but your BMI might be 40. So if you're unhappy with the answer you get from one transplant center, feel free to get a second opinion. But very good, everyone answered that question. 94% of you answered that question well. So it's associated with all of the above as we discussed. Next slide, please. Interestingly, you would say, well then, okay, if the transplant centers want us all to come in at a lower weight, nobody loses weight after transplant, pretty much everyone gains, it's just a matter of how much they gain, and that people who are overweight do worse after kidney transplant, well, let's just get everyone on dialysis to lose weight. Well, that's not a very good idea, because interestingly, what happens with transplant is opposite of what happens on dialysis. Heavier patients do better on dialysis than lighter patients. And patients who lose weight quickly on dialysis don't do well. And why this occurs, it's not clear. Some people think it's because the people who maintain their weight on dialysis or gain weight on dialysis, well, they just have the ability and the desire to have access to nutrition and food. Whereas the people who don't, maybe they don't have access to the food or nutritious food, their caloric intake is lower, their protein intake is lower, and we all know that people don't do well when they don't have a good diet. Or alternatively, kidney failure and dialysis tends to be an inflammatory process, similar to what we talked about with cancer, in that you have inflammatory molecules like cytokines and so forth that prevent you from gaining weight. And maybe and the people who are heavier on dialysis, maybe they have less inflammation than the people who have lost weight and are thinner. But anyway, it's not a clear why it occurs. But you want to be very careful about losing a lot of weight on dialysis or being really, really thin on dialysis. Heavier patients do better. Now, I do want to say I'm talking about body mass. I'm not talking necessarily about weight or fluid. So I'm not talking about, well, I'm 6 liters over my dry weight, I'll do better. That's not what I'm talking about. I'm talking about body mass, fat, muscle, bones, skin, so forth. And as we talked about, most transplant programs have weight restrictions with the obese, because we just talked about the obese patients have more complications. And the restriction is usually a BMI of between 32 and 40, and that's often surgeon and transplant center specific. Next slide. So if this is where the conundrum occurs. If you've been told by your transplant center that you need to lose weight to get on the list or to have your living donor kidney transplant, you need to do it very, very carefully, and much more carefully than is done in the general population. So it needs to be under the watch of a doctor and a dietitian. And every dialysis unit has a dietitian. Most chronic kidney disease clinics are affiliated with a dietitian in some degree. So get a referral from your physician with, I want to be at this weight so that I can get on the transplant list, and help me do that in a healthy way. Because if you do the opposite, if you do one of the crazy diets that you see in TV or in the magazines at the grocery store, you're putting yourself at risk as a patient with kidney failure, because poor nutrition, and particularly protein malnutrition in people who have kidney disease, results in poor outcomes. And what might happen, even if you're successful at losing the weight, you're going to lose a lot of muscle mass, which is not what we want to lose when we have kidney problems. So do it very, very carefully under the supervision of your dietitian, your physician, and your healthcare team. Next slide. And interestingly, and I tell my patients this because my patients get very frustrated, and don't just concentrate on the weight. If you look at the general population, no one's done this study for people with kidney transplant or kidney disease, but my guess is if they did, it would look about the same. Obviously, the people who have the longest longevity and the less medical problems are the people who are at a, quote, normal weight and who are physically active. That's common sense, as you would think. However, the next best to be, if then you have to choose between one or the other, is to live the longest life and to have the least health complications. You would want to be physically active even if you're overweight. And this is particularly important for my post-transplant patients who are frustrated about their weight and their weight gain. That's, obviously we want to stop the weight gain. That's, let's make sure we've adjusted our diet so that we're not gaining more weight. Let's maintain. But now let's start to shift to concentrate on physical activity, because overweight and physical activity is the next best you want to be. Those people actually do better in terms of longevity of life, quality of life, and health complications than people who are at a normal weight but are sedentary. So physical activity now is going to be a major player in maintaining a healthy weight, particularly after transplant, but it's also important before the transplant for this reason. You want to get that lifestyle appropriate for what you're going to do after transplant, because we just talked about it, no one loses weight after transplant. And then obviously, and this is the common sense part too, people who are overweight and sedentary have the least longevity and the highest health complications. Next slide. So in patients with kidney disease, dialysis and transplant, if I were to give you a recommendation, which of the ones would definitely provide positive results? So I want everyone to be a physician for a minute. And now you're going to tell your patients, you need to walk X amount a day as a kidney patient to get a health benefit. So everyone be a physician for 30 seconds. Interestingly, so now obviously there's no perfect answer to this question, because there, as a nuance, I asked you, you had to choose one of these. As a nuance to this, basically getting people moving that are sedentary in my life as a physician is the biggest thing I can do. So getting those sedentary patients that I have, either pre or post-transplant, off the couch and just moving, that's the biggest thing for me to do in general if you took all my patients. But if you made me choose one of these, the correct answer, believe it or not, is only 4,000 steps a day. So it really doesn't take that much activity in people with kidney disease to see a benefit. And this is also not just life. I mean, this has a mortality benefit. So if you walk 4,000 steps a day as a dialysis patient, you live longer, but you're also able to improve your quality of life because you're able to do more, and your blood pressure is lower, and you're on less medicines, and you feel better, and so forth, and you build muscle, and you're less likely to be disabled as you get older. So it really doesn't take that much. So 4,000, and it's interesting, many of you hear the 10,000 steps a day, which is what I try to do. It's what I have on my phone. There's really not a lot of good data that 10,000 steps is the accurate marker. And in fact, many people think it's closer to about 7,000 in the general population. That's the mark where going from 0 to 7,000, you get a big benefit. Going much above 7,000, you get incremental benefits. So, but if we can encourage our transplant patients and our dialysis patients and our pre-transplant patients to do 4,000 steps a day, will have a bigger impact on their lives. Now, human nature being what it is, maybe we tell people 10,000 steps a day and then they'll actually do 4,000. There's that component of it too. So I will still often tell people 10,000 steps a day, knowing that, hey, if I tell them 10, maybe they'll get 4 or 5 and that'll work. Next slide. And so it's really important. Now, if you want to really start to prepare for a transplant or to really maintain a good, healthy lifestyle after transplant, once you get that 4,000 steps a day of walking, you want to add a little bit of resistance or weight training to your large muscles 2 to 3 times a week. And it really doesn't matter how you do it. You don't have to go join a gym. You don't have to buy a bunch of weightlifting equipment. We're talking about using your large muscle groups in your legs and your arms 3 times a week for about 15 minutes. And again, if you have issues, if you have orthopedic issues or you have other issues that might affect your ability to be that active, talk to your physician and they can help you work through that. There are physical therapists, occupational therapists, exercise physiologists. To be honest, I think in kidney disease, we have not been as aggressive in using our other colleagues in those professions as, say, our cardiologists have, or our orthopedic people have, or our pulmonologists have for our other chronic diseases. So don't be afraid to ask for that. But adding that little bit of resistance activity in the large muscles. And so I used that example today with the patient. Carrying the laundry basket around the house, that counts. Going out and raking leaves, that counts. So it doesn't have to be that you have to go out and buy Nike and Under Armour yoga pants and join a gym and do some intensive, hire a personal trainer, do something like that. We are talking about small amounts of activity. Lifting soup cans while you're on the couch. That's what we're talking about. Doing something with your kids where you're using your large muscles 3 times a week for 15 minutes. That would be ideal after you add the 4,000 steps a day. Next slide. So here's a question that I often get from my patients. So maintaining a renal diet would prevent my weight gain after transplant. True or false? Oh, good. So again, good students on the line today. So yes, that would be false. And so I do want to be careful how I answer this question because I'm going to assume that most people will leave with decent kidney function after transplant. Remember that about 10 to 20% of kidneys transplants don't work well right away. And so those patients would need to stay on a renal diet until the kidney kicks in a few weeks or months. So watch their potassium, watch their phosphorus. But the majority of people, the kidney works right away, and you don't have to be on a renal diet for that. But remember that a renal diet, because you're trying to limit the protein and limit the phosphorus and limit the potassium and limit the salt and limit the water, it tends to be high in carbohydrates and fat. A matter of fact, so before dialysis was widely available in the United States, which started in the 70s, so in the 1950s and 60s, when people would have kidney disease and it was hard to get dialysis and transplant was in its infancy, in people who had kidney failure, you would try to avoid them becoming symptomatic by having them do a large dose of butter balls for their calories. So you would take butter, you would put it in the freezer so it would harden a little bit, and then you would roll it in sugar, because the fat and the sugar would allow the people to get calories and stay alive, but it would limit the amount of calories that were from protein, because when you have near end-stage renal disease, so when you're at the time when you need dialysis, if you get a lot of protein, your urea will go up and you will get symptomatic. You will get nausea, vomiting, and so forth. And so you can avoid that by doing butter balls. Now, we start people on dialysis well before that happens in today's world. We transplant people well before that happens. But on dialysis, if you look carefully at what the dietitian is recommending for you to do, you'll see it's a little bit overweighted in fat and carbohydrates for that reason. So we'll want to flip that diet. When your kidney transplant starts working, we're going to want to decrease the carbohydrates. We're going to want to decrease the fat a little bit, and we're going to introduce a little bit more higher quality protein. And that's the other point. Not cheeseburgers, not things. We want high quality protein. And we want fruits and vegetables, because now potassium in most people, and again, this is generalization, so you have to consider your own situation individually, is you want to do that. So the renal diet versus a transplant diet would be, the renal diet is protein controlled for the reason I told you before with symptoms, but in today's world, it's because that's a major source of phosphorus. So they're careful about that. There's more liberal use of carbohydrates and fat in this diet because they typically don't cause a problem with dialysis. They do, however, over the long term can cause a problem with weight gain, diabetes, atherosclerosis, and other things if it's overdone. And then because of potassium restriction and a little bit of the fluid restriction, it's lower in fruits and vegetables. So immediately after transplant, you're going to flip that to less carbohydrates, more fruits and vegetables, and probably more protein or proper protein intake, and a higher quality protein intake. With that, also taking into consideration that, remember, we put a new engine in the car, so you're probably going to want to do all that and probably eat about 200 calories less than you did on dialysis. And that all sounds simple, but that's really hard. I mean, I'll be honest with you. I'm supposed to be losing 15 pounds. That's what my doctor told me. It's really hard, and I don't have kidney failure, and it's really hard. So these things are not easy. They look easy on paper, but there's something to think about. But then if you have a plan going into transplant, it's more likely to be successful afterwards. Next slide. So in this one, we talked a little bit about people who are overweight going into transplant, how we can change things. We've talked a little bit about the people who are overweight after transplant. What if you're normal? So you're saying, well, this doesn't apply to me. I'm normal. I'm getting a kidney transplant. What's the chance in the United States that you will be obese at 1 year after transplant if you were normal at the time of transplant? So yeah, so you're almost got it correct. It's about 30%. So even people who are normal, and so this is probably one of the reasons why this is such a problem is if you're normal, people aren't talking to you before transplant that this is going to potentially be a problem. But for 1 out of 3 people who are normal prior to transplant, they will be obese a year after transplant, if we use the definition of obese at a BMI of 30. So even people who don't have a problem, about a third of them will have a problem after transplant. So it's really important to have a strategy after transplant for everyone to avoid this. Next slide. So lastly, what strategies to avoid weight gain? And I wish I could tell you an easy answer, and there's not. So if you want an easy answer, there's something that a lot of other people I've heard say, and I don't know who to attribute this to: eat less, move more. So that's probably the best I can tell you after transplant to try to avoid this. But realistically, everyone needs an individualized plan. If a third of people who have a normal weight prior to transplant become obese within a year in the United States, we clearly need a plan for everyone. And that likely needs to be individualized. So I would ask for that after your transplant. Every transplant center has to have a dietitian. Now I realize that how they implement those dietitians is not perhaps as standard as it is in dialysis units, but every transplant center has to have a dietitian as required by Medicare. So someone is there to help you with this, and I would ask for that, and ask it to be individualized. More than my suggestion above of eat less, move more. So how many calories should I eat? And what type of food should I eat? And what proportion should I eat? How active should I be? And what kind of activities am I allowed as my wound heals? And I'm on all these medicines. And maybe I'm still hypertensive because they gave me a lot of saline with transplant. And how do I prevent from getting a hernia? So what kind of activities should I be doing? And when can I increase them? And what other things can I do? Your medications contribute to this, although people overplay the role of some of these medications. I mean, there's no question that prednisone stimulates appetite. There's no question that both tacrolimus and prednisone change metabolism. But in studies where people have removed those, people basically don't lose weight. I mean, their blood sugars might improve, their cholesterol might improve, their blood pressure might improve, but weight loss has not really occurred. And then lastly, we talked about a third of the normal patients will become obese. Almost 20% of people who are not diabetic prior to transplant will become diabetic in the next 5 years. So that's another thing we need to take into consideration, particularly if we use prednisone and tacrolimus, is I need to be careful about my carbohydrates, my concentrated sweets, and so forth, because I have a 20% chance of being diabetic, which then brings into a whole other role of complications and problems. And I believe that's my last slide, and I'll be happy to take any questions or comments.
Thank you, Dr. Miller, so much. We have received several questions over the course of the webinar, so I will begin by reading some of those aloud to you. So first question is about the 4,000 steps recommendation, and they're wondering if the 4,000 steps can include walking at home and work, or do they have to be extra?
No, it's 4,000 steps a day. And so I've actually started to, in my patients, because I'd like to say I believe everyone. I'm a little bit more skeptical than that. I'd like to believe everyone. So I've made them all start to download apps in their phone, because most of them carry phones all the time with them. And I want to see the steps. Now, some people avoided me by just saying, well, I leave my phone on my desk and I don't wear it at home and so forth, so it's not accurate. But it's per day. All the studies have shown that it's your activity during day. Now, if you're trying to get, for heart health, so if we're talking to a cardiologist and we're trying to do the best thing for my heart, yes, you'd rather do it in a little bit more vigorous, concentrated time and get that heart rate up. But that's not what we're talking about today. We're talking about that first step to getting active and all these other benefits. And in that includes all your activity during the day, at work, at house, interrupted, and so forth. You know, and if I were training you for, you know, an athletic event, we would do it differently, but that's not what we're talking about. And if we wanted to have an optimum benefit for your heart health, we would try to tell you to do a little bit of it concentrated so you get your heart rate up. That's a great question.
Okay,
and again,
another question.
Yeah,
Sorry,
the point,
go ahead.
I was going to say the point being to people is don't be intimidated. You don't have to join a gym. You don't have to take an hour out of your, you know, after you've done everything you have to do all day and you've dealt with your kids and your dog and your spouse and, you know, everything, all the hassles we have to go through. You don't have to find another concentrated block of time. It's just enough activity. So again, it's just getting that first initial activity that has the biggest benefit.
Thank you very much. We have lots of questions coming in, so please keep them coming. Someone is asking, what do you believe are the most successful strategies that dietitians use in dialysis centers for weight loss? And have you actually seen success with patients working with an in-center dietitian to lose weight?
I wish I had an answer that you'd be happy with on the first question. It's hard because remember the average age of a dialysis patient in the United States, especially one that's, well, it's increasing, but the ones that are getting transplant is still in the 50s. It's really hard to lose weight in your 50s with any condition. And then you add dialysis to it and half our patients are diabetic, it becomes hard. So there's no easy way to do it. And when you're on dialysis, you have the additional problem that if you lose weight too fast, you will lose muscle mass and you put yourself at risk for complications from weight loss. So it has to be done really carefully. So there's no easy answer to that. It's a combination of diet and activity and what types of food you eat and food diaries and having a dietitian work with you. Now, have I had success doing that? Yes. So I am blessed to work with really good dietitians by and large at the dialysis centers I go to. And some of them are overstretched and I get frustrated at that. It's hard for a dietitian who has to cover 150 people in 3 geographic distributions to have that individualized plan for 150 people. But most dietitians that I've worked with have been willing to do that and have had some success. And also, to be honest with you, those are the patients that I mean, I'm speaking for dietitians now. So if a dietitian is on the phone, correct me if I'm wrong, but these are the people that the dietitians like working with. They don't want to go harangue people about their phosphorus being 8 or something like that. They want to work with people who are saying, hey, help me out. How can I improve things? So I would say yes. Most of the dietitians I work with have had some success at doing this in dialysis centers.
Great, thank you. A few people actually have asked, where can I find good information on acceptable exercise post-transplant and also on dialysis with an access? And it seems like there's little to no information out there.
Yeah, there's not much. So, you know what, let me look at that. I know that various organizations, including the National Kidney Foundation, have intermittently put out advice. I know that both of the large dialysis organizations on their website have some generalized advice. Let me pull some of that together, Ashley, and I'll get it back to you, and then maybe you can email out some of these resources to people attending the conference. What I would tell you
Sure.
after transplant is ask your physician and your healthcare team and your coordinator, because there are some issues after transplant. One, we want that incision to heal, and remember that they go right in the lower quadrant and you're cutting through muscle and fascia. So you are at risk for a hernia until that heals. So you want to make sure that, you know, my advice to most of my patients is not to do anything other than really walk for about 3 months until that incision is completely healed. But that's patient dependent. So ask your surgeon, ask your healthcare team about what type of activity and how you can advance it. But remember, there have been 2 people who went back to the National Basketball Association and played pro basketball after kidney transplants. So having a kidney transplant, you can resume normal activity in general, but ask your healthcare team specifically for you.
Great, thank you. And I will put in a little plug here that American Kidney Fund has a webinar actually on exercise during dialysis, which is on our website, kidneyfund.org/webinars. And that would be great if you have other resources that we can post to the website on the webinar page once the webinar has been, the recording has been added.
But remember, if people, and encourage the people, most of the people that are on these calls are people that are already doing most of the right things. We're preaching to the choir today. So if you could go back and you could look to the right and look to the left when you're around other patients and get them to not be sedentary, you will have a major impact on health. The biggest benefit is getting our sedentary patients to not be sedentary. And probably most of the people on this call are probably going the extra mile, which is great. But individualize that with your healthcare team, and keep in mind that people went back to the NBA and played basketball with kidney transplants. So there really should be no limit to what you can do in general.
Absolutely, thank you. So someone is wondering, in addition to walking, what other types of activity would you recommend for a patient before and after transplant?
So here, I'm not sure whether to answer that from a physician standpoint, a scientific standpoint, or just an average guy standpoint. So I'm going to answer it from the average guy standpoint, and maybe a little bit with the physician. So as I get older, I realize that it doesn't matter how smart I am or what I can say or how hard I work, but if I try to fight human nature, I will not be successful. And it doesn't matter how eloquently I present my case. You have to take into consideration human nature. And if I tell you to do an activity that you don't enjoy, I don't think that's going to remain for the long term. So find an activity that you want to enjoy. Like, for example, my wife can walk on a treadmill, and we have a treadmill in our basement. I hate a treadmill. I absolutely hate it. It's just boring. I want to walk outside. So I can do that. And I like doing that. And we have a dog, and the dog likes going outside. So I go outside and walk. Don't try to put me on a treadmill. I hate it. And then for the other physical activities, find something you like. Find something that you enjoy doing. Find something that you look forward to doing. For me, that's for golf. For my wife, she likes playing tennis. For my daughter, she likes playing basketball. My young son likes riding his bike. Find something you enjoy, because you will be more likely to keep that up. That would be my answer to the question.
Great, that's good advice. So someone has a question about bariatric surgery and what your recommendations are for whether people with kidney disease should consider it and whether it could help with some of the weight problems.
Boy, really great question. Really good question. And that is a hot topic right now in kidney disease in general. And let me elaborate a little bit why it's a hot topic. So if we go, and remember, almost half our patients in the United States have kidney disease because of their diabetes. So I'm going to concentrate on those patients and not so much people that have other kidney diseases, because half of them are diabetic. If we go way upstream of our type 2 diabetes epidemic and we get people to lose weight and be active, all of a sudden they are more likely to not have kidney disease, and they may not even have diabetes after they adopt the lifestyle, the diet, and then they have their bariatric surgery to lose weight. So there's a possibility that way upstream that may have a benefit. That hasn't been proven, but theoretically there's that benefit. Now the question becomes, well, is bariatric surgery recommended for me before transplant so I can qualify for the transplant? And no one knows the answer to that. But again, I'll answer it to you in a common sense way, is I think even for the obese patient, getting a transplant is more valuable than staying on dialysis. Even though I know that the patients with obesity may have more complications after transplant, I still think that if you take all comers, they're better off getting a transplant with those complications rather than stay on dialysis. Therefore, if that means that you have to get bariatric surgery to get the kidney transplant because you've tried everything else and it doesn't work, I think that's an option people should consider. Now, there's some issues with that after transplant. For example, one of the things that happens in most people with bariatric surgery is they start absorbing oxalate more from their diet, from their bowels into the blood. That oxalate then can deposit in the kidney and cause inflammation after your kidney transplant. So there, it's not like a one and done. There are some issues with absorption of medications, vitamins, minerals, oxalate after the bariatric surgery. I have had a few patients that are on dialysis go through the bariatric surgery and then get transplanted, and I think it was the right decision for them. But this is something that really needs to be thought through individually because there are all kinds of potential complications and side effects. But if you made me answer that question, if that's the only way I'm going to get a kidney transplant and it were me, I would probably strongly consider doing that. I don't like having surgery though, so I'm going to exhaust every other option before I do that.
Great, thank you. So we have a few questions about kind of the opposite side of the spectrum, which is being underweight. And a few people are wondering, what are the best strategies to gain weight if you are underweight? And specifically, someone is asking for a child. So kind of answering for the adult and for the child perspective of gaining weight.
Well, so I'm an adult nephrologist. I do take care of children 15 and above. But if you're below 15, I will refer you to one of my colleagues. So I'm probably not the best person to answer that per se. So I'll answer it in general for somebody with kidney disease. And we're talking about somebody pre-transplant or post-transplant? I'm guessing
they didn't specify. I would say pre, likely.
Yeah, because this is almost never a problem post-transplant. So I would guess it would be pre-transplant. The first thing I would do is make sure that everything regarding your medical treatment is being done correctly. So make sure your dialysis is adequate, that it's being done well. If you have diabetes, make sure that it's controlled. Make sure all of those things are correct. And then make sure there's not another condition going on that could potentially impact the weight. For example, hyperthyroidism, an endocrine problem can sometimes cause weight loss and so forth. So I'd make sure that. Then I think you work with the dietitian and you increase the caloric intake in the best way possible. Even if that means, and this is where it gets controversial, and if there are any dietitians on the call, I apologize. I know my dietitians don't like when I say this, but if we have a choice of being underweight or having my phosphorus and other lab values look normal, I will tell the patients to eat enough to get us back up to where their weight should be. And then once we do that, then I'll deal with the fact that maybe the phosphorus is too high and the potassium's a touch high and so forth and so on. But work with the dietitian to do that.
Thank you for the recommendations. Someone is wondering, how do the transplant medications, immunosuppressants or otherwise, specifically affect the metabolism? What do the medications do to the metabolism?
So the tacrolimus probably affects the beta cell in the pancreas, just by the way it works. And then prednisone has a whole host of metabolic effects. It makes you more insulin resistant. There's a long, complicated answer to that question, but prednisone has a lot of diverse metabolic effects on your body, and there's side effects. So they happen when you take the drugs. The good news is that at the doses that people use now, which is usually 5 milligrams or less, the side effects are much less. So when I was a medical student, resident, and fellow training, and kidney transplant patients would often be on 20 milligrams for 6 months or a year after kidney transplant, people would develop all kinds of metabolic complications. They would get the Cushingoid facies, the buffalo hump. They'd have the increased abdominal fat deposition, all of those things. Those typically don't happen at the lower prednisone doses people use, but prednisone has a lot of diverse metabolic complications that cause these problems.
Great, thanks. So what do you think about the vegetarian diet? A few people have asked about this for both pre-transplant and then post.
So I'm going to answer that a little bit differently in vegetarian. I'm going to say I like the idea of a plant-based protein diet. I think there's something to be said for that. And substituting plant-based proteins for animal proteins. Now, in general, and particularly in my part of the country, everyone eats, well, not everyone, but most people eat too much protein, period. And then the quality of their protein is poor. So in my area of the country, if you look at all the patients in general, and obviously, some of the dialysis patients, I want them to eat more, but if you take all my patients that I see for various reasons, I'm really focusing on A, you're probably eating too much protein. B, you're eating poor quality protein. And then if I can fix those two things, then I go to C, particularly in my people with kidney disease, and say, maybe we should substitute a plant-based protein for your largely animal-based protein. So I view that as kind of the third step after we correct the first two.
Thank you. Another question, what would you think of a diet that is low in carbs and high in healthy fats for people post-transplant?
For people post-transplant or pre-transplant?
Post-transplant.
So, yeah, no, I think, yeah, that'd be great. Now we have to be careful, and this is where, so I'm getting a little bit scientific on this call, which is really not the intent, but the reason too much protein is a problem in people with kidney disease, in addition to if you're near dialysis, it can cause symptoms like nausea and so forth. But if you take a huge amount of protein, the amino acids cause the blood vessels in your kidney to constrict. It decreases blood flow to the kidney, which then that also causes high blood pressure in the kidney itself. And so that's the reason why we want to not be on an Atkins type diet, or probably even a South Beach type diet, or take creatine supplements or all the things that the weightlifters do if you have kidney problems, because it can affect the blood flow in your kidney. So I like the idea of more of a Mediterranean diet with the healthy fats, low carbohydrates. I think that's a reasonable suggestion to do after transplant.
Okay, well, we're kind of wrapping up here, and the questions have slowed down some. I guess that, if you have any final recommendations for people out there who maybe have been battling weight post-transplant. Someone said they've been battling their weight post-transplant for 15 years. Just what am I doing wrong? If you have any final recommendations for some steps that people can begin making to make that change.
First of all, don't beat yourself up. As you saw from my presentation, weight gain after transplant is the average. So don't beat yourself up. And then I think the next thing is, if you're 15 years out, are you still gaining weight? If you're still gaining weight, we need to get on top of that right now, because that needs to be addressed now. My guess is you're not. My guess is you gained the weight in the first couple of years, and you kind of bounced around a little bit up, a little bit down for the subsequent 10 years. And don't beat yourself up over that. And then if you want to, you can work with your dietitian or try to do some long-term plan where we try to lose 2 pounds a month or 1 pound a month, half a pound a month, something like that to maybe lose a little bit. But the first thing I would say is don't beat yourself up. The second thing is, as we talked about, if you're still gaining weight, address that now.
Great. Well, thank you so much, Dr. Miller, for your thoughts and very useful information that I think people can really use to start making some of those changes if they're ready.
Very good. I enjoyed doing it.
So this concludes today's webinar. Our next webinar will be about sexual health, sexuality, and kidney disease. The webinar will be held on Thursday, July 18th and hosted by Dr. Toby Gottenheiner and social worker Emily Watson. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When our webinar closes today, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining today, and we hope to see you again soon.